I was hoping not to be the first presenter after lunch, but so here we go. My name is Michael Idowu. I will be presenting on behalf of the College of American Pathologists. Before I start, I just want to make a brief statement that many of the codes, many of the services within molecular pathology and genomic sequencing procedures, they have comparable codes in CPT with similar resources and technologies. And so most of the codes I'll be presenting today are going to be crosswalked. They're going to be crosswalked to codes that have similar resources. So the first two codes I'll be presenting are BRCA codes for reconsideration. The first one is 81163, which is the BRCA1 and 2 full sequencing and full sequence analysis. We believe that given the resources and the similar technologies, complexities, it is best crosswalked to 81408. And so, again, this is because we believe this code, the two genes, BRCA1 and 2, have similar resources, and the technology in this case are similar. The next code is 81165, which is BRCA1 gene, and it's full sequence. And because the first code, 81163, is a combination of both, we believe that since this is 1/2 of 2, it's best that we use a fraction of the first code I presented. So in this case, it will be half of 81408. Okay. The next code I'll be presenting is 813X1, which is PALB2. And this is full gene sequencing of PALB2 gene. And we believe that this is best crosswalked to PMS2 gene, which is 81317. We'll mention that the ACMG presented earlier that APC is another crosswalk to think about APC gene. And we think they're comparable. At this point, we do not entirely disagree with ACMG, but we believe it is probably best to crosswalk this to PMS2 81317. And similarly, we have the known familial variant of PALB2, and we think it should be crosswalked to the known familial variant of PMS2. Again, we acknowledge the fact that ACMG prefer APC gene in this case. Now, the next code is 8XX01, PIK3CA. And this, we actually believe, is probably best crosswalk to 81314, which is a platelet-derived growth factor receptor alpha. We acknowledge the fact that an earlier presenter would like to crosswalk it to a different code, but based on our expert panel, expert opinion for CAP, we believe 81314 is probably the best crosswalk for this gene. The next code I'll be presenting is 8XX0X, which is cytogenomic neoplasia. We agree with an earlier presenter. We believe this is best crosswalked to 81229 because of similar resources and comparable technologies that are used in this case. And 8XXXX, which is an infectious agent detection by nucleic acid for Mycoplasma genitalium. We agree with an earlier presenter that this should be crosswalked to 87491, again, due to what we believe will be similar resources used and comparable technologies that are used in this case. And then I'll entertain questions if there are any.
Thank you. Are there any questions or those on the line? If not, we'll continue with our next presenter. Presentation number 33. Hi, how are you? You go ahead and push forward.
Thank you. Good afternoon. I'm Jeffrey Bush, and I am presenting today on behalf of QIAGEN regarding their PartaSure assay and the CPT PLA code they sought to describe this assay, 0066U, placental alpha microglobulin 1, PAMG1, immunoassay with direct optical observation. And at first blush, it might appear that this is a simple case for crosswalk. There's another code that references the PAMG1 biomarker. However, I'm here today to explain to you why that would not be the most appropriate approach to assess this code, and rather the gap fill will be a more fair and equitable approach to determining how this test should be paid. The reasons for that are a couple, and you'll probably recognize a theme developing among some of the other presenters, but specifically this particular assay, by comparison to other assays that utilize the existing code on the fee schedule, is in fact have different indications for use, and so clinically have different applications. Additionally, the FDA regime through which the various assays have gone is substantially different. For example, the codes, or rather the tests that are currently coded under this 84112 code have gone through the FDA review under 510K status versus the PartaSure assay that went through a full pre-market approval process, or PMA. And as we all are quite familiar, I think, at this point, the PMA process is far more rigorous than the 510K process, and as a result of that, tends to lead to substantial increases in development costs that need to be captured. So again, this then means that provider acquisition costs are obviously affected. So what we're talking about here, of course, is with the PartaSure assay is preterm labor. This is a big problem in U.S. healthcare. This is not a big problem for Medicare, as we all know. However, the relevance to Medicare relates to the relationship to Medicaid payment policy, and I'll address that on a subsequent slide. The problem is significant, though, and many patients present to emergency rooms with the symptoms of preterm labor. And the reality of this is that most of those patients are not in labor. They simply have symptoms, in their various and significant publications that make very clear that the symptomology alone is completely insufficient in order to identify patients who are actually going into labor. In fact, about 30% of all those patients who present to an emergency room preterm end up getting admitted into the hospital, yet 85% of them are not going to deliver within 7 days. So this is where the advent of biomarkers has come in, and in fact, biomarkers have become a standard in identifying patients who present with symptoms alone. And so for biomarkers, of course, the goals are pretty straightforward in terms of what we're trying to accomplish. First of all, we want to, as accurately as possible, identify those patients who are, in fact, going to go into labor and treat them appropriately. On the other side of that equation, of course, and the vast majority of patients, we want to rule them out and get them out of the system and not continue to pay exorbitant costs for treatments that are unnecessary. So PartaSure comes to the equation as a new biomarker in the space, and a couple of key benefits that, and I won't go through each one here today for time's sake, But key benefits are, of course, a very high negative predictive value, indicating that sensitivity is very high. In the clinical trials of the PartaSure assay for that PMA ultimate approval, the PartaSure assay was tested head-to-head against the fetal fibronectin assay and demonstrated, again, a very high negative predictive value, but also demonstrated the potential to significantly reduce false positives relative to existing assays. So substantial benefit there as well that ultimately can result in cost savings. Specifically, as an example, taking the clinical trial data with that head-to-head study against fetal fibronectin, PartaSure demonstrated the ability to substantially reduce the number of false positives that might be encountered by the average U.S. hospital, and that could lead to the savings to the tune of nearly $750,000. So a significant potential relative to that. So just to reiterate here, the test itself costs more than other preterm labor assays and premature rupture of membrane assays that are also related, of course, and that's largely due to FDA requirements and post-market study requirements that come through that PMA process. Also, as I indicated, different indications for use versus other assays is the fact that the PartaSure assay has to detect a very minute level of the PAMG1 molecule by comparison to other assays that don't need nearly as, they will detect it at much higher rates and thus less need to get down to individual molecules. Another key factor and one of the key benefits related to the addition of the PartaSure assay is the time, and time to results critical in these patients. So ultimately, the potential to have a very rapid result is important, and the PartaSure assay provides for that, as is noted in the CPT code description, that direct optical observation, which allows a clinician to review and determine the result optically versus having to go and run through a instrumented type of an assay. So potential time savings and time to treatment for patients who do need to be treated. And then, as I already mentioned, the PartaSure assay to date has the highest positive predictive value of assays in this space. So again, reduction of false positives can lead to substantial cost savings. We're not here today, obviously, to discuss what the price should be relative to a gap fill amount. We simply share this in terms of supporting the need for gap fill here, given that the costs for this assay are substantially different from those that might be captured under other tests, assays, and the related coding. And just a quick note here again, Medicare has a long history relative to recognizing that Medicare payment policy does set an upper limit for Medicaid payment policy, and since this is a significant issue in the Medicaid population, then we submit that the agency has in the past demonstrated the willingness and ability to adjust payment relative to specifically this area, and should do so in this case through the gap fill process, given the opportunity to do that at this point. And so lastly, I will simply summarize that, again, our recommendation for CPT code 0066U is for gap fill on the basis that it will be the only fair and equitable approach to evaluation and assessment of the resources required to provide this test in a clinical setting. And I thank you for your time, and we'll take any questions if there are.
Are there any questions for those on the line? If not, we'll continue with our next presenter. Presenter number 34, Association for Molecular Pathology. Hi, how are you? Just go ahead.
Excellent, thank you. Good afternoon, everyone. I'm Nino Cerecci with AMP, and I'd like to thank you for the opportunity to present our recommendations. So we'll be commenting on far fewer codes than we did for the previous years, and here's an outline of what we'll be talking about. So in general, our basis for crosswalk recommendations are the same as they've been from years past. We look at the technologies utilized in the particular procedure, overall resources utilized, the type of detection, the type of genomic variant that's being detected, and of course, the amount of genomic material interrogated. And where possible, we try to make a connection in terms of the clinical application of the code. So we'll start with the Reconsidered Molecular Pathology Code. We've seen some recommendations from our colleagues on 81163, gene analysis, BRCA1 and 2, full gene sequencing, and AMP will reiterate its initial recommendations to crosswalk this to 81408, the Tier 2 Molecular Pathology Code for sequencing of exons greater than 51 and greater. It's important to note that the reason why we're reiterating this particular recommendation is because the final determination of 81406 plus 81216 does not adequately cover the resources required for full gene sequencing of BRCA1 and 2. A review of the concert genetics database reveals that NGS and Sanger sequencing are the two most common ways to analyze BRCA1 and 2, and at a value of $468, there are no laboratories that would be able to perform, there are very few laboratories that would be able to perform this service. So we reiterate again the crosswalk to 81408. Similarly, the full gene analysis or full sequence analysis of BRCA2 is 81408 times a multiplier of 0.5 for similar reasons as were described. We'll move on to the new molecular pathology codes. The first is PALB2, full gene sequencing. This is crosswalk to 81317, PMS2. This is based on the overall similarity in the size of the gene, number of nucleotides sequenced, and the resources required for this type of analysis. And for consistency's sake, and similar to how we've approached similar types of crosswalks in the past, we've crosswalked the known familial variant code for PALB2 to the known familial variant for PMS2. The next code is PIK3CA, gene analysis, targeted sequence analysis of exons 7, 9, and 20. And here we recommend a crosswalk to PDGFRA, targeted sequence analysis of exons 12 and 18. I should note that AMP did not consider the cost associated with CDX development for PIK3CA, as this code is general for the analyte and not for the specific methodology. And felt that this was an appropriate crosswalk. Our next crosswalk recommendation is for a cytogenomic neoplasia microarray analysis. Again, this is for analysis of cytogenomic abnormalities in neoplasia. And this is crosswalk to 81229 for the pretty straightforward reason that this is exactly the same type of methodology that you would use for germline or constitutional microarray, simply a different matrix. And we'll end with our new microbiology crosswalks. This is a code for Mycoplasma genitalium identification by DNA or RNA by nucleic acid amplification. We agree with our colleagues at Hologic that a crosswalk to 87491, which is nucleic acid identification of chlamydia trachomatis by nucleic acid amplification, similar resources, similar technology used, same instrumentation. So it seems to be a very reasonable crosswalk. With that, I'll take any questions.
Are there any questions for those on the line? If not, we will continue with presentation 35, functional fluidics. Okay, continue with okay.
How long do I have?
10 minutes. and you progress with this one right here.
Okay, very good. Hello, my name is John Cunningham. I'm speaking on behalf of Patrick Hines with Functional Fluidics. Functional Fluidics is a blood function diagnostics company developing assays for sickle cell, for measuring disease condition in sickle cell disease. We're presenting 3 different assays today that measure the adhesion of red cells and the mechanical fragility of red cells. This assay is the first assay, 021U sickle cell disease microfluidic flow adhesion on VCAM. This is a functional assay where we're measuring how cells in whole blood stick to VCAM as a substrate of interest. And we're recommending a crosswalk to code 86352, which is a similar, which is a blood function assay at least. And the current pricing for 86352 is $150.96. How do I advance this here? The second assay, 0122U, sickle cell disease microfluidic flow adhesion to P-selectin of whole blood. It's similar to the earlier assay. In this assay, we're using P-selectin as the protein of interest. We're flowing the sample across a microfluidic channel and then enumerating the number of cells that stick to the protein. We're recommending again a crosswalk to 86352. The third assay, 0123U, mechanical fragility, RBC, shear stress, and spectral analysis profiling. This is on a different platform than the first 2, but it's a related assay and has complementary functions to the first 2 assays. In this assay, we stress the sample with a whole blood sample with a bead mill and a magnet, and then we non-invasively measure the amount of hemolysis over a period of over several time points to establish a risk, a pre-hemolytic risk profile. This also we are recommending 86352, consistent with the code descriptor. Then our rationale, so all 3 of these assays are lab developed tests. We run them in our lab, our CLIA certified lab in Detroit, Michigan. They're all high complexity tests, and our justification is that 86352 is also, it's not the exact same type of assay, but it is a blood function assay with a similar level of complexity. So again, our resources, we're using a microfluidic plate, VCAM1, a microscope, a robotic tray, pneumatic pumping system, and a controller, and then we're taking a series of photomicrographs and then enumerating the cells that stick to the channel. For 0122U, very similar to the preceding assay, except that we're using P-selectin as a protein of interest. And just to note, 86352 is an immune cell function assay where the sample is stimulated with a T-cell antigen mixed with magnetic beads, and then the ATP concentration is compared with a healthy control. So it's a similar level of complexity. And then for our third assay, 0123U, again, the sample is mechanically stressed over multiple time points, and then free hemoglobin is measured in the sample. That's my presentation. Any questions or?
Are there any questions for those in the audience?
Hi, Karen Nakano, CMS.
Hi.
Just very simple question for you for the first 2 tests.
Yeah.
In your slides, your rationale is that the descriptors are comparative, but again, based on, I just want to make sure I understand this, they are similar only in terms of the fact that they are functional tests. What is the phrase you use to describe how they are similar?
They're similar to the extent to which they are that they're sort of highly complex blood function testing. So it's basically treating a sample and then measuring a response from the sample.
So how is would your test, in what situation would your test be preferential over the other tests that would identify the 86352 or 86552?
It's a completely separate application. So the code that we're suggesting to crosswalk from is an immune cell function test that's used for sort of for pre-surgical procedures. Our tests, we're proposing to use them as a disease condition monitoring tool for sickle cell disease patients. So we're proposing that these tests become a standard of care during quarterly routine visits with sickle cell disease patients to provide these measures to help physicians to control the disease condition and keep it in a maintenance state instead of escalating into a crisis state.
Okay, thank you.
Step right there. Are there any comments or questions for those on the line? Great, thank you. We'll continue with our next presenter. Presenter number 36. Right there. So you just push that one to progress.
All right, thank you. Hi, and thank you for having me here today. I'm Elizabeth Donley. I'm the CEO of Stamina Biomarker Discovery and our business unit, NeuroPoint DX, which is a leader in diagnosis and precision medicine of neurological disorders. I'm here to recommend crosswalk of our code 0063U to 0003U based on the similarity of equipment, resources, and diagnostic methodologies of these two tests. This code is the first diagnostic using metabolism for autism. It quantitates 32 amine-containing compounds using clinically validated methodologies via LCMS. The thresholds and algorithms created for this assay are the result of a clinical study, the largest study of the metabolism of children with autism ever conducted. The NIH-funded study, the Children's Autism Metabolome Project, or CAMP, has established accuracies of greater than 95% in 30% of children with autism based on differences in metabolism. The goal of this test is earlier diagnosis as young as 18 months, as well as information on imbalances in the metabolism of these children that may inform more precise treatment. The American Academy of Pediatrics recommends every child be assessed and screened for developmental delays in milestones, language communication, or regression in social language skills, and also children that are the younger siblings of already diagnosed children with autism. ASD can be diagnosed through behaviors as young as 24 months. However, the average age of diagnosis in the United States is more than 4.5 years. And during these critical years that are lost, children miss opportunities to improve their developmental milestones and ultimately their outcome as participants in society. We're adding children to the autism population at a rate of 1 in 58. We have 3.5 million people in the United States that are living with autism. So this is an enormous societal burden, and it's well established that earlier intervention can really improve outcomes for children and families. This test offers the opportunity for the first time to diagnose as young as 18 months rather than taking a wait-and-see attitude as often is the case. The test is, the behavioral testing that is the standard of care is offered by neurodevelopmental specialists and not frontline physicians as pediatricians and family practitioners. And so there is a need for a test that can get kids identified sooner and referred on for neurodevelopmental assessment. Our test is very similar to 0003U in that it incorporates analytical methods for collection and preservation of blood plasma, requires shipping on dry ice and freezing within 1 hour. We use mass spec, LCMS-based mass spec, for quantitation of amine-containing compounds, and then apply the thresholds and algorithms that have been established in our clinical study, the Children's Autism Metabolome Project. The goal is to generate a diagnosis, either positive or negative, for 30% of the children, with referral immediately to a neurodevelopmental specialist for those who test positive. Those that test negative can be evaluated using other methodologies or retested at a future date. The direct costs, including the supplies, depending on the number of samples that are screened, range from $119 to $340. Also required expensive dedicated equipment. The triple quad with LCMS runs about $400,000. In addition, highly trained staff are required both to do the analytical methodologies in-house and to apply the diagnostic algorithms. And the transportation on dry ice also is a significant cost factor for us. We have two supporting publications here. The first, Smith et al., is the first publication from the CAMP study, which describes a portion of these diagnostics contained on the panel that we're presenting today. And West et al. Was the original proof of concept work we'd done prior to the NIH-funded study. So again, we recommend a crosswalk of our code 0063U to 0003U. Because of the similarities of the methodologies, resources, and equipment required for each of these diagnostic tests. We quantify 32 amines versus the 5 proteins that are quantified in 0003U, but the resources and equipment are very similar. With that, I will take any questions that anyone has about this. Thank you very much.
Are there any questions for those on the line? If not, we'll continue with our next presenter. American Society for Clinical Pathology.
All right, thanks. All right, well, thanks, Dr. Arthur. I'm going to be very brief because we submitted a detailed list, a spreadsheet with all the information. We've collaborated with the other organizations, with ACLA, with AMP, with CAP and others, and the information that we present really is very similar. There's no reason for me to walk you through this presentation. I'm sure you'll appreciate if we don't. So we've collaborated on those. I'd also like to just make a quick comment about the PLA codes as co-chair of the PLA committee. It's been our pleasure to bring you 70% of the activity today on a quick count. And I think that there's an opportunity for us to work together as we develop new codes. And I would actually encourage all of you to work with us, with the AMA CPT team that is developing those codes to bring better clarity and a streamlined process. And to that end, we would encourage you to contact the AMA team if you're going to submit a code early so that we can help with it rather than the scramble at the last minute as we try to get it out. So I'm not going to, we handed out the specifics. They've been provided to CMS, and I'm not going to walk you through those again so that you'll like me instead of hate me. And I'd like to congratulate Dr. Arthur for getting us through this incredible list so incredibly quickly.
Thank you. We'll be moving on to our next presenter. Myriad. Here we are. You progress with that one right there.
Thank you.
You're welcome.
Good afternoon. I'm Benjamin Roa on behalf of Myriad Genetics to present our recommendations for 2 of our molecular codes. So these are 815X0 EndoPredict, which is the crosswalk to 81519, and 0090U, MyPath Melanoma, which is for gap fill. So 815X0 is the code for Myriad's EndoPredict test. This is a molecular oncology test performed on formalin-fixed paraffin-embedded breast tumor tissue and uses mRNA gene expression profiling by quantitative RT-PCR and an algorithm to report a risk score for use in breast cancer management. Previously, CMS had crosswalked other breast cancer prognostic MOS to a comparable test described by CPT code 81519. EndoPredict is used by physicians in the management of patients with early-stage, ER-positive, HER2-negative breast cancer with 0 to 3 positive lymph nodes for whom adjuvant chemotherapy is being considered. Chemotherapy comes with benefits as well as risks of safety and quality of life issues. The prognostic ability of EndoPredict to classify patients into a low-risk or high-risk group for developing distant metastasis was validated in multiple published studies. Prospectively designed retrospective studies were performed on 3 different cohorts from phase 3 trials, which included over 2,600 patients who received 5 years of endocrine therapy alone. These studies satisfy a 1B level of evidence according to the classification for prognostic biomarkers proposed by Simon et al. The EndoPredict methodology uses quantitative RT-PCR to measure mRNA expression of 12 genes combined with algorithmic analysis of the results. These include 8 genes that assess cell proliferation and estrogen signaling pathways, 3 genes for RNA normalization, and 1 gene for DNA contamination. So following algorithmic analysis, the test report provides both prognostic and predictive results. The workflow for EndoPredict starts with anatomic pathologist review of the H&E slide, followed by macro dissection of FFPE breast tumor tissue, RNA extraction, qRT-PCR, and algorithmic analysis of the results. This culminates in a patient report with prognostic and predictive data for breast cancer released to healthcare providers. And the workflow is very similar to that of 81519. 815X0 is most comparable to Oncotype D Express 81519. This is based on the 2 tests sharing the same breast cancer sample type, the same test methodology that is performed in a centralized lab setting, and the same test function that provides prognostic and predictive information for breast cancer management. In contrast, 815X0 is not comparable to Prosigna 81520 based on differences in test methodology, where our test uses qRT-PCR versus Hype capture, and the test being performed is an LDT in a centralized lab versus an IVD kit that is sold to labs. Therefore, based on multiple measures, Therefore, based on multiple measures of test comparability, we recommend that 815X0 be crosswalked to 81519. So switching gears, I'd like to present our recommendation for Myriad's MyPath Melanoma test code 0090U. This test is performed on FFPE melanocytic tissue and uses mRNA gene expression profiling by qRT-PCR and an algorithm to report a categorical result for the diagnosis of benign skin lesions, indeterminate or malignant melanoma. We recommend gap fill since no other MOS for melanoma diagnosis are currently available for crosswalking, and we are hopeful that we will receive an ADLT designation for this test. The purpose of this ancillary molecular test is to aid in diagnosing melanocytic skin lesions with ambiguous histopathology characteristic of benign nevi or malignant melanomas. The MyPath Melanoma test provides new, unique clinical information by reporting a classification of benign, malignant, or indeterminate, which assists in the diagnosis of ambiguous cases. The test is performed on FFPE melanocytic skin tissue with ambiguous histopathology, and the method used is quantitative RT-PCR to measure the mRNA expression of 23 genes. These include 14 biomarkers and 9 normalization genes, followed by algorithmic analysis of the results. And the test report includes an individual score that represents the probability that the melanocytic skin lesion is malignant or benign. The MyPath Melanoma workflow starts with anatomic pathologist review of the H&E slide, macro dissection of the FFPE melanocytic tissue, RNA extraction, qRT-PCR, and algorithmic analysis of the results, culminating in a patient report with diagnostic information of benign or malignant melanoma released to the healthcare provider. The diagnostic accuracy was demonstrated in 3 published clinical validation studies which demonstrated consistent performance among 3 separate cohorts comprising over 1,300 melanocytic neoplasms. The first 2 validation studies showed 90 to 93% diagnostic accuracy by comparison of the test results to consensus diagnosis by multiple expert dermatopathologists. And the third study confirmed accuracy and also showed clinical utility by comparing the test results to documented patient clinical outcomes. MyPath Melanoma is covered by a local coverage determination by Noridian, effective June the 3rd, and it has been used by approximately 500 physicians and 30,000 patients since test inception in 2014, and the list price is $1,950. We recommend gap fill for 0090U because a comparable MA for melanoma diagnosis does not exist for crosswalking. The MyPath Melanoma test provides new clinical diagnostic information, and we're hopeful that we will receive an ADLT designation for this test. Thank you very much. Questions?
Are there any questions from those on the line? If not, we will continue with our next presenter. Hi, how are you? Progress with that one.
Okay, great. Good afternoon. I guess we're at the final stretch here. I'm Lee Sean Acklog. I'm the executive chairman of Lucid Diagnostics. We have an assay called EsoGuard 0114U, which is a diagnostic test to NGS-based for methylation of 2 genes in the 2 genes for to detect Barrett's esophagus. We're recommending a crosswalk to which that actually should be 81519. The rationale is it's a genomic test. It utilizes specific biomarkers, PCR of the genes, and an advanced bioinformatic algorithm. So I'm actually going to pass the microphone on to Dr. Joseph Willis, who's the vice chairman of pathology at Case Western University and University Hospitals Cleveland, where the assay is performed.
So our new code is called EsoGuard, and as Lishan was saying, this is a test an NGS-based test that identifies the presence of methylation in 2 genes, methylated vimentin and methylation at the cyclin A1 gene. And these signatures we have identified as being sensitive and specific markers for the presence of Barrett's esophagus. The basic concept is of this technology is uses bisulfite sequencing, DNA extraction, and a complex algorithm. So the test purpose of EsoGuard is to detect Barrett's esophagus, low, high-grade dysplasia, and esophageal adenocarcinoma with a high degree of sensitivity and specificity. Once a presumptive positive diagnosis is made, then the patient will then be referred to a GI specialist for review and further evaluation. A negative result then, based on this assay, will mean that patient can safely avoid the risk and costs of this low-yield diagnostic process we call it, and EGDs. I want to thank the CEO for Diagnostics, who gave a really excellent presentation about the real problem we're having currently with esophageal adenocarcinoma, one of the more common, increasingly lethal diseases in the last 20-odd years. But in spite of that, endoscopic therapy for these patients is rather limited. The ability to find these patients in general population is low. A lot of patients have heartburn that don't necessarily equate to the presence of Barrett's esophagus. So we think we have a methodology to fill that void. This is the assay process that we put in place to give you some idea of the complexity of the assay. So when the specimen is received, we do a DNA extraction. We then do a bisulfide conversion of the DNA. And then because we have two genes, methylated and unmethylated components, there are 4 PCR-based amplifications. After that, there are standard processes such as the gel electrophoresis verification that the PCR products are correct. Then the standard cleanup of the PCR amplified DNA, which, as you know, can be laborious, as well as that the standard, then we put this through next generation sequencing. After that, we use our complex algorithm to identify this, to look at the sequence data, and then after that, then the data is transferred to a molecular pathologist for interpretation, and a final binary report for the presence or absence of Barrett's esophagus is identified. And these are just some of the functionalities that are present in the algorithm, such as mapping of since this is bisulfide converted DNA, the DNA has to be mapped to a bisulfide converted genome. After that, we have 31 individual DNA bases per DNA molecule. That's 21 for one of the molecules and 10 for the other. And then we determine the methylation density that has to meet a certain threshold for Vimentin, as well as a methylation threshold density for CCNA1 in order to go forward. As well as that, then you have to determine the percentage of those molecules for the presence or absence of methylation. And then after that, then there has to be a computational component to decide whether or not there is a positive or negative result. As well as that, there are multiple quality assurance steps at each step of the way that have to be verified by the algorithm. This is, we're just going to show you 2 sample sets to show the robustness of the assay. These are ROC curves. On the left, you can see that methylated Vimentin, and in the middle graph showing methylated for CCNA1, both having AUCs of over 90. And the 2 bar graphs on the right are a composite of those patients identifying for the presence or absence of non-dysplastic Barrett's esophagus in that population. And this is a second data set. I think you can see what's really interesting is that in the final column, where either methylated Vimentin or methylated for CCNA1 is present, all these numbers of percentage positives or specificity are greater than 90%. So non-dysplastic Barrett's, patients with esophageal adenocarcinoma, patients with dysplastic Barrett's of various sorts were all identified to a high degree of sensitivity and specificity with this assay. So these are 2 of our supporting documents from recently published material on the assay. So then finally then, we do want to crosswalk to the CPT 81915, and the rationale is that this is a genomic test. It utilizes specific biomarkers as a multi-complex PCR basis of gene, and it has an advanced diagnostic algorithm. With that, I'll take any questions. 81519, sorry. Any questions? All right. Thank you very much.
Thanks. Are there any questions for those on the line? If not, we'll continue to our next and final presenter. Thank you. Presenter number 40, M Labs.
Hello. My name is Yashar Nicknaps. I'm with M Labs. We're at the University of Michigan. What do I aim this in? Okay, so we've developed a diagnostic test for prostate cancer. It's a urine biomarker test. And we are recommending crosswalk with 0005U, which is a test that is similar to ours in almost all the same ways except for some of the sample preparation and our test performance. So for some background, the clinical utility of our test, it's for prostate cancer diagnosis. So right now, in a clinical context, PSA is used as prostate cancer screening. Elevated PSA is very nonspecific. So a lot of people are going to get referred to urologists. There's about 1 million prostate cancer biopsies performed every year. Only about 10% of these will result in detection of clinically significant cancer. So most of the time when a prostate biopsy is done, it is unnecessary. So there's a high clinical need for a better test that can reduce the number of unnecessary biopsies. So the clinical utility of our test is that when a patient has elevated PSA, there's an elevated suspicion of prostate cancer, they will oftentimes be referred to a urologist, and the current clinical decision-making path is to go to biopsy, and then depending on what happens with biopsy, there's further treatment. Our test is called MIPS, the Michigan My Prostate Score. Its performance is quite good with regards to sensitivity and NPV, and so with a sensitivity of 97% and an NPV of around 98%, we can rule out 25 to 30% of unnecessary biopsies. So if a clinician or patient is concerned about cancer, kind of the tagline is, if we perform MIPS, we can successfully rule out over 98% in over about 25% of the cases. So cost and savings, obviously when someone is told they have prostate cancer, there's a high psychological cost, especially when only a small fraction actually have high-grade disease. This is a surprising number. Actually, 5% of biopsies on average will result in infection. These are transrectal biopsies. And somewhere between 1 to 2% actually result in hospitalization. So prostate biopsy is a high morbidity procedure, and again, there's a high need for both the sake of the patient, but also from a financial standpoint, there's a lot of wasted money in these fairly expensive biopsies. So our test measures the expression of 3 genes in the urine. So urine is collected from the patient following a prostatic massage. And the thought there is that prostate cells will shed into the ureter, and then on first void, you'll catch it in a tube. RNA is then isolated, and target gene expression levels are quantitated using a method called transcription-mediated amplification, which is a fluorescence-based method very similar to qPCR. We measure the genes KLK3, PCA3, and then the TMPRSS2 ERG fusion. KLK3 is the RNA that makes PSA, and that is used as a normalizing factor because if you need to if you're quantitating RNA in the urine, you can get bladder cells, kidney cells, so that's kind of a surrogate for how much prostate actually ended up in the urine. PCA3 is a long non-coding RNA, highly specific to prostate cancer, and the TMPRSS2 ERG fusion is a pathognomonic fusion for prostate cancer, very specific. So these 3 values are used in an algorithm to generate a risk score. So we're recommending crosswalk to 0005U, which is this EXO-DX prostate score. If you read the description, it's a prostate gene expression profile using RT-PCR of 3 genes. They use ERG, PCA3, SPDEF from the urine, and then there's an algorithm reporting a risk score. So ultimately, it's almost the exact same test. Instead of detecting ERG, we detect the T2 ERG fusion, and the sample acquisition is slightly different. They don't use a prostatic massage. We fulfill the same clinical need. We both are assessing RNA levels in the urine. We are using analogous methods to quantitate the RNA, and they measure the same gene PCA3 and then a similar gene ERG, but not the cancer-specific version of ERG. And then both of these tests are using an algorithm to produce a risk score. Thanks.
Are there any questions from individuals here in the audience? Okay, we'll begin.
Dr. Vicky Pratt, I'm on the PLA.
Hold on for 1 second. You talk to Mike.
Dr. Pratt, you have to tilt the microphone, the tail end up, and you're going to see a small switch on the top. And when you switch it on, you'll see a light come on, and then you'll know you're okay.
All right, Dr. Vicky Pratt, I'm on the PLA, or the play tag, and I'm just confused by your descriptor. Your descriptor, as published, is measurement of 2 biomarkers in urine, but in your presentation, you're saying you're measuring 3 biomarkers, and I just wanted clarification on that.
Sure, yeah. So we are measuring the third marker. So PCA3 and TMPRSS2-ERG are the clinically significant markers. The third gene is KLK3, which is measured as a normalization factor. So 3 genes are normalized, but there are 2 that are put into the algorithm, and the third is just a normalization factor.
All right, you may need some clarification in your descriptor because that's not clear.
Sure.
So this is Karen Nakana again. So I have a question for you regarding your crosswalk of 0005U. Can you tell me how your test is different from 005U if it appears that your code descriptors are sort of similar? In other words, why would someone use your test as opposed to 0005U?
Sure. So we are detecting a different gene. So even though TMPRSS2-ERG and ERG sound similar, the gene fusion is actually a very unique event that's specific to prostate cancer. So we are measuring something different. So half the test is a different gene, and our test has far better performance. So I guess that would be my response to someone asking why they should do our test.
So the question is, I guess what would help us is understanding when would your test be more appropriate than the 0005U?
It would be, well, I think that both tests would be utilized in the same clinical niche, but we are suggesting that our test should be used instead because of its better performance.
Thank you. Dr. Arthur, we have received a question from one of the panel members, and it's in reference to one of the prior presentations.
Okay. Could you indicate the presentation number? And
So it was presenter 39, the EsoGuard group. And it's a relatively simple question. I don't think they need to go up to the podium. They can just come up to the microphone. And the question is, what they want. The panel member wants to know what is the crosswalk that they are using. It was not clear.
Yeah, I think there was a typographical. The CPT code is 81519.
It's instead of 0047U. 81519. Okay, thank you very much.
Okay. Are there any questions or comments related to session 1? Okay, this concludes session 1. We can give everybody a round of applause. We were able to accomplish 40 presentations in the time allotted. So what we're going to do right now is we're going to give a 15-minute break to prepare for session 2, and we'll start promptly at 2 o'clock. At this time, I want to ask everyone to take their seats. We're going to begin with session 2. And for those online, thank you. So session 2 will begin with some opening remarks from Corinne Axelrod, who is the Deputy Director of the Division of Ambulatory Services.
Thank you, Rasheeda. Hi, everybody. First, I'd like to thank all of you that are still here. We really appreciate you coming, and we appreciate you staying here, and thank you to everybody who is also still online. I think there is quite a few people that have either dialed in or are watching on YouTube, so we are very happy that you all are able to participate. Before I start talking about automated test panels, I want to first say that Sarah Shirey-Losso is very sorry that she wasn't able to be here today and wants you all to know she would much rather be here than homesick in bed. So she's just wanted to say hello to everybody and apologize for not being here. And I really also just want to acknowledge our staff, who I think have done a great job in managing this conference. It always seems so simple, but there's a gazillion little details. So in particular, Rasheeda and Laura, Dr. Nakano, and the other staff that have been helping out, Lisa, Glenn, and if I omitted anybody, my apologies. But thank you all for putting on such a great meeting. So. So I'm going to talk about automated test panels. And just as a little bit of background, prior to PAMA, the 23 chemistry tests were grouped together via a claims processing algorithm. So this algorithm took into account the economies of scale when more than one test was done on the same day. The ATP 2 through 23 codes were assigned a payment. And under PAMA, we can no longer use this claims processing algorithm. These 23 chemistry tests are high-volume tests and have led to significant increases in spending. The GAO, which is the Government Accountability Office, in its November 30th, 2018 report, said that Medicare expenditures could increase by $218 million for panel tests that lack billing codes. As an example of how much the payment for these tests has increased, we have this slide here which shows on the left the number of tests performed, the 2017 payment, and the payment under PAMA. So for instance, if you look at the very last line, if all 23 tests were done on the same day, which I know is not common, prior to PAMA, the payment would have been $16.64, and it would now be $137.93. So that's a pretty significant increase. The Clinical Lab Fee Schedule Advisory Panel met on September 12th of 2016, and they came up with two possible recommendations. The first one is basically to do what we're doing now, which is paying them separately, which is how we're directed to do under PAMA. So that recommendation would be that we would pay for the CPT panels and for single test CPT codes using data gathered under PAMA. The other option that they recommended is that we use PAMA data for CPT panels and that we create G codes based on the number of analytes performed for any additional analytes billed beyond the CTP panel. So the potential options that we have come up with are to create separate U codes for 2 through 23 combinations of the chemistry test orders. For example, if there are 2 tests ordered, that would be U0002 for a combination of 2 chemistry tests. U0022 would be a combination of the 22 chemistry tests. Another option is to create 5 tiers of U codes for ranges of any combination of chemistry tests ordered. For example, we could have U002, which could be 1 to 3 chemistry tests, U003, which could be 4 to 10 chemistry tests, or some variation of that. So what we wanted to do today was tell you what the issue was and the options that we are looking at, and get some feedback from all of you as to the options that we are presenting, and if you have any other possible options that we should consider. So I know this is very brief, but it's pretty basic that this is the issue. We're paying a lot more money now than we did before. We can either continue doing that, we can come up with some U codes that would group together some of these codes, or perhaps there's some other options. So I'm going to stop now and invite people to comment. I think that there are 2 people that had actually signed up to comment. What is this one? PACA. PACA is first, and then ACLA. So if you wouldn't mind coming up to the microphone, that would be great. Oh, did you want them to use the one down here? Oh, there's a microphone down there. Yes. I don't want to relinquish my podium. So you have to turn it on. The button is on the back.
Do you want me to face this way, or do you care? Okay, I'll look at everybody. So, good afternoon. My name is Esther Stein, and I'm speaking today on behalf of the Point of Care Testing Association. The PACTA comprises manufacturers of in vitro diagnostic test systems ordered and furnished directly in patient care settings to allow for effective and efficient incorporation of diagnostic test results into patient care decision-making. PACTA appreciates CMS's continued diligence in monitoring its payment systems for potentially abusive billing practices. However, we urge CMS to proceed cautiously when making additional changes to payments under PAMA for these tests. Since the implementation of PAMA, CMS has processed claims for automated chemistry tests using CPT codes for each test, including codes for individual analytes or codes for panels as described in CPT as appropriate, and set payment rates at the median of private payer data reported by applicable laboratories. This process is entirely consistent with the intent of the PAMA statute. We understand CMS's concern that all labs bill appropriately and accurately for tests performed for Medicare beneficiaries, and that labs not unbundle panels where there is a CPT code that describes such panel. PACTA believes that utilization data from calendar year 2018 clearly show that unbundling of CPT panel codes is not occurring, nor is there evidence suggesting improper billing for automated chemistry test panels. In its November 30th, 2018 report, the GAO asserted that labs may be disregarding longstanding CMS and AMA CPT billing guidelines, and that mass unbundling of panel tests might have been occurring. GAO concluded that if such mass unbundling of panel test codes was occurring, this would result in billions in access payments. We believe that it was not appropriate for GAO to infer that unbundling was occurring and that laboratories were being paid in excess of what they should be paid without evidence to support such claims. Based on a review of CMS utilization data from 2018, there was no evidence of unbundling in laboratories' billing practices for automated chemistry panel tests. Following the implementation of PAMA, out of tens of millions of claims, when automated multi-channel chemistry tests were billed, laboratories billed using the panel codes more than 99.9% of the time. The percentages are comparable before PAMA rates were implemented and after. If labs were unbundling panel tests, particularly to the extent that GAO presumes, we would expect to see dramatic differences. This is simply not the case. However, if CMS is concerned that there may be program vulnerability, we strongly recommend that CMS perform a robust data analysis on more than a single year's worth of data to verify if such vulnerabilities exist. CMS can then apply its existing program integrity tools to implement targeted corrective actions rather than penalizing the entirety of the lab industry. Also, there was no direction in PAMA, nor through CMS rulemaking, that directed any shift in billing practices for organ and disease panels. Laboratories have continued to follow the long-standing CPT guidelines from the American Medical Association, directing all providers to use the most specific code available to describe services provided. In addition, the 2019 National Correct Coding Initiative Policy Manual for Medicare Services provided instructions that clearly require billing a panel code when such is available. For tests that were previously bundled together by CMS under its ATP grouping policy as part of claims payment rather than coding, PAMA does not provide CMS with the authority to reinstate a code grouper or to otherwise create new HCPCS codes that would arbitrarily replace valid CPT codes describing automated chemistry tests for payment purposes. In fact, PAMA anticipates paying for diagnostic laboratory services at the weighted median of rates paid by commercial insurers, and to do otherwise, as suggested by GAO, would be in direct contradiction to congressional intent. Implementing a group coder or new HCPCS codes in 2020 would render moot any data collected during the first half of this year and subsequently reported to CMS in early 2020. These data would not be collected based on the codes in effect in 2019. Terminating these codes in favor of new codes would prevent CMS from setting market-based payment rates for these tests until at least 2024. There's also no guarantee that these new codes would be recognized by private payers at all, calling into question whether and when market-based payments could be established. In summary, PACTA does not believe that there is sufficient proof that laboratories are billing in a manner which would necessitate CMS taking action. We believe that the current coding and payment system is working as it is intended. We strongly recommend that any actions taken by CMS should be done with the utmost transparency and in a manner that allows for stakeholder engagement to provide feedback to address CMS's concerns. Thank you.
Thank you. Do we have a copy of your comments? You do, good, okay. And does anybody have any questions on what she just presented? Okay, then I believe we have Akla who wants to also address this.
Good afternoon. My name is Julie Connie. I'm the president of the American Clinical Laboratory Association. It's been a long day, and I'm the last speaker of the day, so I'm well aware of that. And I also don't want to duplicate the comments in the presentation of CMS or the previous speaker. So I am going to skip through the section informing everybody about how automated multi-channel chemistry tests were paid for in the past. And also that organ and disease panels are also used and continue to be used. Where I do want to start, however, is that the previous payment system for AMCC tests is inconsistent with PAMA requirements. PAMA requires that prices be reported on a test-by-test basis, and reporting prices for bundles of different AMCC tests is not permitted. So recognizing this inconsistency, CMS appropriately abandoned the reimbursement formula and, as required by PAMA, began paying separately for each individual AMCC test. Now, questions were raised about how laboratories were billing the Medicare program for these tests since January of 2018 in the November 2018 GAO report. And as the previous speaker mentioned, GAO suggested that laboratories could, and I want to emphasize could, be billing for these automated chemistry tests by unbundling the claims and paying for the billing and then being paid for the individual tests instead of the panel code. So GAO, based on that, set forth a hypothesis. They said, what if? What if every laboratory in the country ignored CPT billing guidelines and began to unbundle these tests? What could that mean for the Medicare program? Medicare expenditures could increase by a very significant amount. Again, the emphasis is on could because that did not happen. That was the headline, but laboratories in no widespread way proceeded to ignore long-established CPT billing guidelines and bill at the individual rate. So we agree that panel tests with billing codes should be paid at the panel codes rate. Laboratories are required to do so based on AMA CPT guidelines, which provide very clear direction. These directions were not changed as a result of PAMA. The way in which, again, laboratories were required to bill for these codes remain unchanged. And also, CMS's December 14th transmittal said that laboratories should report the panel test where appropriate and not report separately the tests that make up the panel. That merely reiterated longstanding practice and longstanding guidance from CMS as well as the AMA. So because of this GAO report and the very significant attention that this report was given by policymakers, ACLA reviewed publicly available Medicare claims data. We looked at what was submitted in the first half of 2017 for the 7 organ and disease panels and their component tests, and we compared that with claims that were submitted in the first half of 2018. So the comparison of the claims submitted before and after PAMA implementation does not show a dramatic increase in the billing of those individual codes. So if laboratories had in fact acted in the way in which GAO suggested, you would have seen the panel codes drop significantly and the billing for those individual tests increase. It simply did not happen. We went one step further, and ACLA conducted a survey of our own members. We did so under privilege regarding claims that were submitted for each of the 7 organ and disease panels using the panel CPT code and claims submitted with the individual component tests. The survey solicited information about claims in the first 3 quarters of 2017 before PAMA was implemented, and then for these same first 3 quarters of 2018 after implementation. We found no change in member laboratories billing. In both the pre and post PAMA surveys, less than 0.003% of claims were submitted with the individual test codes when all tests in a panel was performed. 0.003%. So the GAO identified a potential problem, but not a problem that is widespread. We certainly agree with CMS's continuing efforts to ensure that laboratories submit claims for organ and disease panels and their component tests appropriately and in accordance with longstanding coding guidance. I also want to take just a minute to address the comments that were made by CMS about increased spending in this area. It's really important to remember these tests in their entirety. Let's look at the individual codes and how they're billed and at those organ and disease panels. And let's keep in mind that we're in the beginning years of PAMA and there are fully weighted medians that are scheduled to go into effect in 2020. The organ and disease panels, and by the way, the vast majority of AMCC tests are billed through the panels, not individually. And when you look at those organ and disease panels, those panels are experiencing some of the most severe reductions under PAMA. Let's think about the comprehensive metabolic panel, which was featured significantly in GAO's report. That is facing a 31% cut when the weighted median is fully implemented. The lipid panel, another very high volume test on the CLFS, a 32% cut. So I would encourage, again, let's look at the whole picture. Let's look at those weighted medians. Let's keep in mind that those codes are billed individually, but the majority of the time, they are billed as part of a panel. When you look at all of the spending in the aggregate, the spending for these tests is going to go down. So in addition to the desire to move to a market-based system, to look at individual rates for individual tests and base reimbursement from a weighted median, you're also seeing and you will see a reduction in spending and overall, and you also have the matter of congressional intent. And again, it was the desire to move to a market-based system based on the reporting of individual tests. So I thank everyone for the time. I thank CMS for the opportunity to speak. And again, I'll not keep anyone longer in the day than they anticipated. Thank you.
Thank you. And so did anybody here have any questions? Okay. And again, can we get a copy of your remarks? And if you want to add on, because I know you added on a little bit at the end, so if you could add that on to your remarks, that would be great as well. Let me ask if anybody on the phone or on the internet or whatever we have going on has any comments that they'd like to share with us at this time. It doesn't seem so. So I don't know about you, but, oh, yes, we have a comment. Yes. Yes.
Hi, this is Karen. Can you please use the microphone?
Hi, I was just asking about any next steps by CMS or potentially the advisory panel in this area.
So that's a great segue. So, I don't know about you, but I always have a brilliant idea after a meeting is over. So if you have any other suggestions about this topic, here is the website that you can send your comments or suggestions to. As was just mentioned, we do have a meeting in July. That's July 24th, I think.
July 22nd and 23rd is a CDLT panel meeting right here.
Thank you. And we are going to go back after this meeting and really, look at all of your comments. And so in terms of next steps, there's nothing definitive that I can tell you at this time, only that we do take your comments very seriously, and it's an issue that's really important for us. So again, we will look at your comments and discuss them, and, we will let everybody know when we're thinking about doing something. It's done through a very public process. So I think that's it for this session. Rasheeda, I'm going to turn this back over to you.
Well, I want to thank everyone again for a very full and insightful meeting. We look forward to seeing you in about a month with the CDLT panel meeting. Don't forget to make sure you've registered for that meeting. And also, if you have any follow-up comments, you have 2 weeks to submit those with the resource box that's designated on the screen. It's due by July the 8th. And if you have any follow-up questions, feel free to also send those questions to that email account. Thank you again, and this concludes our meeting.